as a supplement. So this ends that first recording, and now we can begin with the second, the discussion of the gas laws. So the gas laws associated with the pulmonary system or the respiratory system are shown on this table. First, the total pressure of a mixture of gases is the sum of the pressures of the individual gases. That's Dalton's law. So two gases we are most interested in are carbon dioxide and oxygen, as you know, but there can be others. We know that nitrogen is present, but they all contribute to the total pressure of a mixture. The second, gases singly or in a mixture move from areas of higher pressure to areas of lower pressure. The third, if the volume of a container of gas changes, the pressure of the gas will change in an inverse manner. You recall, and this is Boyle's law, but this also is true. So this Boyle's law is for a gas, but the same thing was happening with the hydraulic pressure, the blood pressure in the circulatory system. We always talked about vasoconstriction being one of the means to compensate for loss of blood. If you have a hypovolemia, then you decrease the container size to keep pressure high. So you're decreasing container size to have pressure stay high or go higher if you need to increase blood pressure above normal. So it's, again, the same inverse manner. But here we are talking about pressure and volume equaling the first state versus equals the pressure times the volume of the second state. So again, you have no gain or loss of materials. The law of conservation. We don't create or lose anything. So what happens is it's a change of energy state. So there's a higher energy state. In this case, we're talking about smaller volume as number 2. So the pressure is going to increase. So the pressure and the volume of a container of gas are directly related to the temperature of the gas and the number of molecules in the container. PV equals nRT is the formula that we're talking about, where N is the moles of gas, T is the absolute temperature, and R is the universal gas constant, 8.3145 joules per mole Kelvin temperature, right? That's the ideal gas law. So these are the 4 gas laws that are taken into account here, and we saw different laws for the pneumatic pressures, excuse me, this is pneumatic here, for the hydraulic pressures of the blood vessels of the circulatory system. So let's begin to think about partial pressures then, where we have some dissolved and some still in other forms. Some can be bound, as you know, but when gases are dissolved in a liquid, we begin to talk about a partial pressure, and we think of those at sea level at atmospheric pressures of 760 millimeters of mercury. So the pressure of the gas equals pressure of the atmospheric pressure, times the percent of the gas in the atmosphere. I guess I jumped to the point of these being dissolved when we can think of their partial pressure. Remember the first law, we said each contributes to the total. Now we're considering the partial total pressure that is contributed by any one of the gases that are in the mixture. Sorry about that. We will transition to thinking of the same thing when you have it dissolved. So the table is showing us the gas and its percent in air on the left, the partial pressure of that gas in dry 25 degrees C air. This is typical room temperature. The partial pressure of the gas in, again, the room temperature with 100% humidity, and then at body temperature with 100% humidity. So we see nitrogen is 78% of the typical air, oxygen 21, and carbon dioxide at 0.033%, and the water vapor. When it is dry, that's at 0, and we see that the nitrogen has the highest partial pressure, 160 for the oxygen, and 0.25 for the carbon dioxide. With the change to a 100% humidity, then we have 24 millimeters of mercury contributed by the water vapor, the PCO2, which is just doing this with the gas being replaced by CO2. The PCO2 of the atmosphere would be 0.24, drop just a 100th of a millimeter of mercury. Oxygen drops just a bit, and the nitrogen partial pressure drops also as well. When we raise the temperature to body temperature, we see that we have PO2 dropping even more, dropped by a total of 10, but we also have, let's just compare from the 100% humidity, since we've humidified the air that we breathed in and we've warmed it up to body temperature, correct? That's what we're basically showing here. So we drop 5 on O2, the PO2. We drop 0.005 on the PCO2, so having this very low favors the movement of gas into the alveolus at the exchange, right, from the plasma into the alveolus. So that's ultimately what we're going to look at, is the partial pressure differentials for each of these at the respiratory membrane, and then the water vapor nearly doubles. Now let's consider Boyle's law. So the gases move from areas of high pressure to areas of low pressure. So Boyle's law is that P1V1 equals P2 over V2. So you should immediately in your brain be able to say that P1 over P2 equals V2 over V1. So that algebraic manipulation should occur automatically for you. And it's not 1 over 1, or 1 over 2 and 1 over 2. It's 1 over 2 on the left and 2 over 1 on the right, because this one comes over here and that one goes over there as the denominators on each side. Decreasing the volume increases collisions and increases the pressure, as you know. So if there's more space for them to wander around, then their forward movement is not deflected in another direction, putting forces on the wall of the container. And that's essentially what's happening, is when they don't have enough room just to bounce around, because everything moves. Remember Brownian movement. There's energy exchange all the time at the atomic level. And excuse me. This bouncing off the walls is what creates that pressure, but we obviously had to apply an external force to reduce the size of the container. Excuse me. A little laryngeal problem there. So the spirometer is what we see in this illustration, and as we're considering flows and pressures, we know that we're going to get to this. So if you've taken a physiology lab, you very likely will have performed this study on yourself or another student in your group and collected a similar type of information and made the calculations. So, and it's you probably don't do it in your lab either, and clinically it's not done this way anymore. There's a little laptop computer with the thing that you blow into, so it's really called a pulmonary function test when we get to it clinically. But here we can see that we're just blowing into a space that's going to have some means by which you measure the air flow and the pressure that can be generated, and then some way of recording it. Well, this is really old. I don't think anybody does it this way anymore. This is all replaced with analog to digital converter. after you have some pressure flow detector, and it feeds into a computer, and then your results are on the computer screen, and you can save it in a file and print it out if you need to. So we see the rhythmical breathing pattern here, obviously. Inspiration increasing the volume. That's pretty strange because this is not what happens. Well, they're just inversing it, right? Because when you breathe in, if the air is going this way, you create a negative pressure. So that must be turned into an upward deflection on this. Is that? Yeah, it's going to lift. It's going to push that up and lower the drum. Is that what's going to happen? Yeah, okay. So the drum is going to go lower, and relatively the pen, which is stationary, is going to make an upward deflection when you breathe in. So this is a drop of the drum here because you created a negative pressure to pull that down, so it is going to measure the volume that you inspired and then the volume that you expired. So at rest, they are equal. And you see that it's roughly a half a liter, 0.5 liters, or 500 mLs. So the resting inspiration expiration volume is a half of a liter, 500 mLs. And so first let's just go right in and recognize this in the graph that we're looking at. Okay, so what do we have for axes? Time. The capacities are the sums of two or more volumes. So we're going to be adding up some of the volumes to get what are called capacities that are very critical to understand the total function of the respiratory system. And then on the y-axis, the left-hand axis, we see volume in milliliters. So there's 1,200, 2,300, 2,800, and 5,800 are the numbers that are shown here. So it is a linear scale. They just don't have uniformly labeled tick marks as we ascend. They're just showing critical numbers that represent the typical adult population. Okay, so this differs with age, and obviously differs tremendously with different disease conditions. So let's go to the left and figure out our legend first. We'll leave some of these summary comments until after we've gone through this panel on the right. So what we are considering then is the four lung volumes. There's that volume that stays there because if you emptied it out completely at any one point in time, the alveoli would collapse. So there has to be a residual volume that is within the large airways, as well as keeping the alveoli open. So the RV is the residual volume. Then the ERV is the expiratory reserve volume. So there's always a little bit more that you can blow out. Then the VT is the tidal volume. Then the IRV is the inspiratory reserve volume. And then let's shift to the panel on the right to see where those fall on here so that we can functionally appreciate the definition as we are experiencing them. So the 1,200 is the residual volume. So this is what would remain if you could breathe out as hard as you could and push out all the air that would seem possible. And then if you could measure how much was left, and there are some techniques for this, it's dilution of other types of gases or markers and stuff like that. But anyway, these are really well known for normal humans and many of the pathological conditions. So residual is 1,200 mLs. And whenever you see numbers, remember, you have to think about age, gender, and any type of compromise to the system, which can be just kind of being out of shape versus somebody being in perfect condition. So the marathon runner is going to do a little better than those of us that spend more time at our computers, as you certainly should know. So always keep that in mind, and have a sliding scale in your mind. That's really important. Then the 2300 is when we add the residual volume to the expiratory reserve, which is nearly equal. It's just 100 mLs less. So they're almost an equal volume. And then that brings us up to the 2300 when we add the residual and the expiratory reserve, so that we are seeing the low level that we typically hit with each resting inspiration and expiration cycle that we saw in the previous slide. So we're going to bounce back and forth basically from moment to moment between 2300 and 2800 mLs. So that 500 mLs is the tidal volume. So you think of the tide, the normal tide coming in and out every day at the beach. It's a typically it's the same amount every night that it comes in and same amount leaves. So if you can associate tide with just the basal level resting in and out, then you've got your tidal volume. So it's not adding anything together. It's the highest point of volume in the whole lung, the respiratory tract, minus the sum of residual and expiratory reserve. So in other words, we typically have 2300, and you take in 500 mLs and you expire, which is still expel, but we use the term expire here, right? Okay, so now when you blow out really, really hard, then you get the from the peak, the end of normal inspiration, all the way down to the residual. So that is one other sum that we can look at, and that's a resting inspiration with a forced expiration. But that usually doesn't give us a great deal of information other than with a relaxed exhalation at rest. Then you blow out as much as you can. It can give an estimation of the expiratory reserve volume, which should be, for an average aged adult, 20s to 30s, I guess we would probably say, around 1100 mLs. Then after a resting inspiration, you draw in the deepest breath you can, and you get the inspiratory reserve volume from the peak of normal inspiration to the maximum that you can breathe in. That's the inspiratory reserve volume, which should be about 300 mLs. So what we are interested in, typically with a pulmonary function test, is to have you breathe in as deep as you can, getting all the way to the peak inspiratory reserve volume, and then you expire as fast as you can and as long as you can to eliminate expire the expiratory reserve as well, and then you breathe back in, and this produces a waveform from which they can get a set of critical data. So depending upon age, the residual volume will be estimated, known from a scale, and then you can get the volume measurement from the peak inspiratory volume to the peak expiratory volume, so you know the downward deflection as a volume, and typically that is around 5 liters. In this case, they're just showing 4,600 mLs. So it depends upon gender, as I said. So a male might have 5 liters and a female, if they're average and comparable, not peak athletic performance. Maybe you stay in shape a little bit, walk some, park far and walk long rather than park close and walk short. Whatever it is, you balance it out, and that's kind of the way we think about this. But roughly 5 liters is the vital capacity. The inspiratory capacity is, of course, the total amount that you can expire from a resting expiration. Excuse me. And then we see that we return to the normal resting inhalation and expiration there. So let's take a look at a couple of these capacities other than the inspiratory and the vital capacity that we just talked about. So if you take everything into account, from the maximum you can breathe in to totally emptying the system, or what is the total volume that you could put into the respiratory system, that's the total lung capacity. And then from a resting expiration, when you add just the expiratory reserve and the residual to get the 2300, that's the functional residual capacity. So the FRC equals 2300. FRC minus ERV equals RV, which is 1200. So these are the kind of games that you need to play and write it on a piece of paper so you can appreciate the formula for each of these. So now over here on the left we see some normal values. So let's look for that vital capacity, which is the, what do they have shown on there? So it's the inspiratory reserve, 3,000 for males. The inspiratory reserve volume for females, about 1,900. And I don't know what populations they're getting to make these comparisons. I don't think that these are athletic, and even women that work out routinely with jazzercise or whatever type of exercises they would do on a regular basis, they might get closer to the 3,000. But anyway, always keep that in mind, that these universal values do not always apply to every single individual. You need to know more about the individual. But in general, on average, if you made a very large population measurement, this is the distinction that you would see for males and females. The VT is the tidal volume, so that's about the same for each of us. The end residual, the expiratory reserve volume is starting to get my cardiovascular mixed up in there, right? The expiratory reserve volume is 1,100 and 700 males versus females, and then the residual volume is offset about 100 mLs smaller for females. So we are going to have differences in vital capacity, inspiratory capacity, and functional residual capacity on a gender basis, on average. So statistics, as you recall, do not apply to individuals. The statistics only applies to populations. So you must always take the individual and compare them to the population and match various parameters as to where they're going to fall on the scale that we would consider normal. So if this is average, there's a plus and minus on either side, and so it's not unlikely that there could be an average, a normal adult female that could have a higher IRV. So airflow is the next topic then. So flow is proportional to the change in pressure over resistance. So delta P over R. So this is the same as what we had seen before. You have to have a pressure differential that acts across a series or a parallel set of resistive structures. Excuse me. So without the pressure gradient, you're not going to get flow. but flow does not occur unless it's flowing in space, and then its association with whatever is near it. If it has walls and contains it, then you're going to have the resistance from the walls that dissipates the pressure force. And the collective actions of all these interplaying and interfacing will determine the flow. So the alveolar pressure or the intrapleural pressure can be measured. So there's this single respiratory cycle that consists of one inspiration followed by one expiration, as we had talked about. So this respiratory cycle was the relaxed breathing in, inspiration, and expiration. So the respiratory cycle can have baseline properties, as I just described, and then we would want to think of a respiratory cycle under other conditions. How would that change with exercise, exertion, and pathology? But let's just think of it in the basic context for now, the movement of the diaphragm. Remember the pleural space, so we defined that as having a thin film of fluid. So these two surfaces, the visceral layer and the parietal layer of the pleura, do not separate. And there's not too much fluid in there. If too much fluid gets in there, the biophysical dynamics do change. And of course, you also lose space. You cannot expand the chamber. You just compress the gas-filled lungs. So keep that in mind with things that can happen to the pleura. What about pleural adhesions from scarring in this area? So many things change the dynamics. So under normal conditions, these slip and slide against each other and they never separate. So any negative pressure that's generated by expanding the chamber is directly dissipated onto the external surface of the lungs and will expand them, creating a negative pressure relative to the opening, which is should only be through your external nares or your nostrils. And we know the diaphragm will expand the thoracic volume by contracting and shortening the distance between the two, the radial attachment around the body wall. So in other words, I'm not saying the distance from side to side, I'm saying the distance following a line that goes right through the center of the plane of the diaphragm. When the diaphragm shortens, it pulls down here, and so its total length from side to side or all the way around is going to decrease, right? So that, of course, compresses the abdominal cavity, but also expands the volume of the thoracic cavity. And that volume expansion is filled with the air, as you know, that comes from the external environment. So in between the lungs is the middle mediastinum, as it is called, and the heart would reside there, as you certainly know. So at rest, the diaphragm is relaxed. It is dome-shaped, most dome-shaped, and then when it contracts, it is less dome-shaped, less concave, more flattened, and therefore it is creating that negative pressure. But also, as you know, the internal intercostals, remember they're over on this side, I'm trying to remember, are acting on the ribs to move them such that they increase the overall diameter or volume effectively of the thoracic cage. And then, of course, with relaxation of the diaphragm, you get the natural return to the more concavity, the greater concavity, the more concave shape, and of course the ribs return to their original position. If there's any degree of forced expiration, or there's even just a bit of reflexive type of contraction of the external intercostals, remember if you stretch a muscle passively, it will contract to some degree, just increase its basal tone. So if you the respiratory system automatically contracts the internal intercostal to expand the volume of the rib cage. Then it's going to stretch the, and I'm just double checking back to the figure. The external intercostal is the inspiratory, and the internal intercostal is the expiratory. So when you contract the external intercostal and it places a stretch on the internal, there's going to be some reflexive contraction of the internal to return the ribs back to their original position and contribute to expiration. So that's under resting conditions. That's how you get all those combined dynamics of the diaphragm and the external and internal intercostals contribute to the 500 ml tidal volume. So anything beyond that is more muscular activity. So let's think of how the ribs accomplish this. So the dimensions of the thoracic cavity during inspiration are going to increase and decrease in their total volume. And it really is from the posterior to the anterior dimension, as well as side to side, lateral to lateral. So the rib is often compared to a pump handle type of a motion that increases the anterior to the posterior dimension of the rib cage. And we see that illustrated here. But also there's the bucket handle analogy where we increase the lateral dimension as well. So when you raise the handle of a bucket, if you think of just the surface diameter of this, when it's down, you look at this just only at the top, and then when you enlarge it, when you lift the handle to the side, the total cross-sectional area, that if you were looking from the top down, would be that. So, forget the rest of the bucket. It's original diameter. When you lift this up, then it's going to be how it changes it. And that's how it would be here. So side to side, this is going to be a greater distance now, and you have a greater volume. So those two analogies help you to understand how we get an anterior to posterior change in the dimension from the movement of the ribs, and a side to side, a lateral change in dimension with the movement of the ribs. The pressure changes during quiet breathing, then, are what we will consider in this slide. So we see the trachea, the two primary bronchi, continuing into the lobar, and very different names as they continue to branch all the way down to the alveolus, as you remember. So we're keeping in mind that full tree, and the pleural cavity is shown here. What we are considering then is the alveolar pressure in the upper panel, the trace labeled A. The trace labeled B is the intrapleural pressure in millimeters of mercury. So the alveolar pressure is millimeters of mercury as well. And then trace C is the change in volume in milliliters of the moved air. So we're looking at two pressures that are going to be correlated with the volume of air moved. So this should obviously trigger in your mind flow. So flow requires is a rate measurement. So we are then looking at this over a timed series. So the change in the volume over time is what? Very good. It's flow, right? Change in volume over time is flow. So how many, this is seconds here, so we'd be talking about mLs per second. So in 1 second, there'd be 250 mLs that flowed over that 1 second period, right? Over 2 seconds, it doubles. So the flow rate is the same across this time series. And the expiration flow rate is a bit different. We don't get the exact crossing at 250 1 second later. It's actually a higher value. So does this mean the expiratory flow rate is higher in the first second than the first second of inspiration? So compare this first second of inspiration. What is the Y value in mLs, and what is the time? And then the first second of expiration. What is the Y value? It's higher than 250. Over still the time differential is 1 second, so you have a higher flow rate in the first second of expiration versus the first second of inspiration. So you should always look at a graph and look at these distinctions and read the graph, not just go, oh, I know what that means, because it becomes very important. Any change in this shift in this pattern gives you cues to what's going on with the pressure differentials that depends upon many different characteristics of the tissues that are involved. Is there some type of a pathology that's a mass, or is it liquid? Is it a scarring? Is it a broken rib? Right. So this is what becomes really important. Not just recognizing the pattern, but very detailed features of the pattern, and any subtle shifts should draw your attention. So let's come all the way up to alveolar pressure then and relate it to the intrapleural pressure and keep track of our flow in association with that. So in the first second of inspiration, we can see that the alveolar pressure goes from 0 to a negative 1.1, let's say, and at the end of 2 seconds it is back at 0, and at the end of 3 seconds from the beginning of this recording, where we are in the middle of expiration, so the peak resting expiratory pressure is about 1.1. So we generate about the same pressure differential from baseline in the negative direction as we do in the positive direction, and that pressure differential of about 1.1 millimeters of mercury is what is required to generate the flow that we see. So this full cycle of going all the way up to 1.1 and then coming back is related with the full flow of 500 mLs of air. The intrapleural pressure, as you can see, has a sweep that looks a little more like the air flow. So it's most closely correlated in a negative fashion, right? So it's negatively correlated with the positive deflection in the flow curve. So as the intrapleural pressure drops, it looks like it's almost linear, but it's slightly curved. But it is this curve over its change over the full 2 second period of inspiratory phase of the cycle looks more like the total event for flow over that same 2 second period. So this intrapleural pressure we would conclude is probably more directly responsible for creating the flow pattern, but it generates a transient intraalveolar pressure change. So this becomes really important. Where this and the couple of other things to note about the intrapleural: it never reaches 0. It's always at a negative level, and it deflects from about -3 to about -6. So you have, in some way, you have a dissipation of this total 3 millimeter mercury drop in pressure and raise back up to that, elevation back up to that, to a deviation of 1.1. So approximately a third of that is experienced within each alveolus. So these are the types of correlations that you want to draw on these. So in other words, as you create this pressure differential over this 2 second time period, across the intrapleural, across the pleural membranes, then that creates a transient decrease and subsequent increase in pressure in the alveolus over that same 2-second period. So first you draw into it, and then as it begins to fill with air, it begins to pressurize a little bit. And it doesn't take a lot of air to accumulate in a space to recover that 1.1 millimeter of mercury. So the subatomic pressure in the pleural cavity is what we are showing in this slide and considering. So we see our airway, and we're considering pressure being dissipated, transduced, if you will, onto the complete surface area on the outside of the alveoli, the full lung surface, right? So we need to think about how we pull on that, create a draw, and how we press on that, create a positive pressure. And it is through the transmural pressure that can change and be directly dissipated, as we saw, to the intrapleural pressure. So this one isn't really using that term, transmural pressure, but you will see it in other physiology textbooks. So we're talking about the elastic recoil of the chest wall that tries to pull the chest wall outward, and then there's an elastic recoil of the lung that creates an inward pull. So these work against each other to create that intrapleural pressure that stays at minus 3 millimeters of mercury, which is subatmospheric. So we recall the intrapleural space and the pleural membrane as the visceral and parietal layers. So the subatomic pressure in the pleural cavity is extremely important. Anything that disrupts it will change all the fluid dynamics, and as well the amount of pressure on the outside surface of the lungs and the residual air that is in the lungs. So with pneumothorax, what we have is a collapsed lung that cannot function normally. So this not only damages the endothoracic fascia, if it also goes through the parietal pleura, then you will get the collapsed lung. But it's hard to imagine that it would just go through a connective tissue layer and then not just that simple squamous single layer of cells. So anything that punctures the chest cavity wall will allow air to rush in. And of course this is one of the reasons you stick your finger in a bullet hole. If you can prevent this from happening, it's easier to recover from it. If you get the full collapse of the lung, then it's harder to get it to return to its full size. So what happens with this is you lose that transmural and transmural function that we just considered, that keeps a negative 3 millimeters of mercury here. If that is lost and the intrapleural pressure equals atmospheric pressure, you collapse the lung. So this brings us again to think about, as we're seeing the lungs inflating and then completely deflating like we just saw there with a not such good situation, we're reminded of how we talked about the blood vessels of being able to distend and then return to their original size. So distensibility and elasticity are interrelated, and the distensibility, we remembered, had that term compliance associated with it. So how easily can you put a volume into a structure and have it expand and accept that without generating tremendously high pressures. So again, we think of blowing up balloons. If you've ever had to blow up balloons, sometimes you'll get one that you can blow up quite easily. So it has a high compliance. If you get one that you're blowing as hard as you can and it seems that it will never just suddenly start to expand, then that has a low compliance. It is resisting the stretch. So it's not very distensible. It has a high elasticity to hold its original shape, but it doesn't have the distensibility. So the compliance is that ability to stretch, the distensibility. So we have a high compliance, then it stretches easily. So if you're really compliant, then basically, you're a pushover, right? If you are a low compliance, you're never agreeing with anything, never doing the things you're supposed to do. So that requires more force. And it's a restrictive lung disease is what we would see if the anatomical changes, the patho-anatomical changes in the tissues caused restrictive lung disease, a lower compliance. So a fibrotic lung, remember we mentioned that, the inadequate surfactant production, so you just don't have that nice Texas clay that stays nice and moist to keep things slipping around and to reduce surface tension. So if you try to slide side to side on dry clay, you don't get much of that going on. But when you're standing in the wet clay after some of the rain we've just had recently here, and finally, you know that you can slip and slide very easily, and feet will slide right out from underneath you. So this is a way to think about it. If you can't slip and slide on the inner surface of the alveolus, then you're not going to be able to blow up the lung very easily. So if you have inadequate surfactant production, then you will have a low compliance. There will be a labored breathing. So elastance is the term for returning to the original size, the resting volume. So when the stretch force is released, then there's the passive return to the original volume. Now we can consider the law of Laplace. So surface tension is created by the thin film layer between alveolar cells and the air. So this is where the surfactant becomes important, obviously. So the law of Laplace is P equals 2T over R, where P is the pressure, T is the surface tension, and R is the radius. So according to the law of Laplace, if two bubbles have the same surface tension, the small bubble will have higher pressure. So the surface tension is in the numerator. So if it increases, then the pressure will increase. So they are directly proportional. If something is inversely proportional, when it increases, like the radius, then the pressure will decrease. So you have two bubbles with the same, let's see, so in this case here on the left, the pressure is greater in the smaller bubble. So radius is 1, the surface tension is 3, and the pressure is 2 times 3 over 1, which is 6. And then here we have the larger bubble, the radius doubles. So if the radius doubles here, then pressure should drop, and by the same proportion, 1/2, right? So pressure does drop. It's only 3 in a bubble twice the size, where surface tension is staying the same. Surfactant reduces surface tension, and then pressure is equalized in the large and the small bubbles. So here we can see with the surface tension decreasing, at the same time you get the decrease in the radius, and if they change proportionally, so if you get half the radius, you get half the surface tension, then you have no change in pressure. So if you change each variable or one variable independently of the other and it stays constant, then you have the change in pressure corresponding mostly to the change in the radius. But if you change both the tension and the radius proportional to each other, so if the radius decreases by a factor of 2, this should decrease by a factor of 2. You get no change in pressure, and that is what surfactant is capable of doing, reducing surface tension proportional to the change in radius within normal functional ranges of changing the radius of our alveolus, such that there's no effect on the total pressure. So surfactant is more concentrated in the smaller alveoli. The mixture containing it's a mixture of containing proteins and phospholipids. The newborn respiratory distress syndrome is related to aberrations of or inadequacies of surfactant. So this is often seen in premature babies where the cellular function, the type 2 alveolar cell, simply has not matured to the point to where it can meet the need. So there's inadequate surfactant concentrations. Now let's think about the airflow in this gas law discussion. So the factors that affect airway resistance are the length of the system, sounds familiar. Viscosity of air, sounds familiar. The diameter of the airways, that sounds familiar too. These are the same factors for hydraulic flow. They are affected by and then mediated by. So these first two are mediated by constant factors or factors in the environment that we typically do not control, but we can. We can make air more humid or less humid if you have a dehumidifier, right? So the length of the system is constant. It's not a factor. Unless you have something that happens, right? You get pneumonia or obstruction, even though they're talking about it here. But if you get, a lobar pneumonia, the lower left lobe, then the length of your system is changing too. But anyway, under normal conditions, we do not change the length. Under pathological conditions, it can. So the viscosity of the air is usually constant. Humidity and altitude may alter slightly with these two. So I mentioned that we had the rain that brought the clay. We also got an increase in the humidity and, of course, allergens. But anyway, so the air is a little more difficult to breathe when it is very humid out. You may not notice that if you're in perfect health and in good shape, but anything less than perfect health and good physical shape, it does become a factor. Someone with allergy-induced asthma, as me, and the higher humidity makes situations where I can feel the difference. So the diameter of the airways, the upper airways, we see physical obstruction, mucus, and other factors. Well, I don't have to tell you about myself on that one and how my allergies affect it. I'm excusing myself for clearing my throat all the time. The bronchioles, the bronchoconstriction is a critical factor there, and this, as we know, is the parasympathetic neurons, the muscarinic receptors, histamine, and leukotrienes. So constant histamine, throw as much antihistamine into me as I can, and it doesn't seem to counterbalance what is happening there, so there's always just a little bit of this going on. The bronchodilation, carbon dioxide, and epinephrine are factors that can mediate these. Remember, this is the beta-2 adrenergic receptor for the epinephrine, bringing about bronchodilation. So remember, this is hormonal from the adrenal medulla, not sympathetic innervation. It is an endocrine-mediated bronchodilation. If you know about the EpiPen to reverse anaphylactic shock, well, the epinephrine gets into the blood and acts on the beta-2 receptors and causes the relaxation. So it's bronchodilation due to smooth muscle relaxation. But the parasympathetic innervation to cause bronchoconstriction is the neural-mediated response. And, of course, the histamine and the leukotrienes are coming from the leukocytes that have moved into the tissue and we showed it getting into the alveoli, but it also is in the underlying connective tissue. These cell types, the leukocytes, this is the mast cell, as you know, and then other leukocytes release the leukotrienes that we had mentioned. And when we get to the immune system, we'll talk about it in more detail. But these are in the connective tissue underlying the basement membrane within the bronchial tubes. So there's a very nice animation. If you have this, go ahead and take a look at it. Again, because unless I have specifically required you to get this for the course, it's supplemental.